Paul, do you want to get going?
Yes, okay. Good evening, everyone. Sorry, we seem to be having some slight technical problems. My name's Paul Lambden. I work for Colosseum and I'm also a dental legal advisor. Tonight, I've got the pleasure of introducing to you Mohammed Isa, who's going to tell you all about periodontal disease. So without any delay, I shall pass you to Mo to let him tell you who he is and what the subject is. Thank you, Mo.
Good evening, everyone. Thank you for the introduction, Paul. Thank you all for joining us on this webinar on a Thursday evening. Appreciate you taking the time to come and listen to us, listen to me speak. The key thing today is we're hopefully going to be looking at perio, periodontal disease, and the medical legal aspects of that. Give you a little bit about my background, just because you're here to listen to about perio and medical legal aspects. You're not really here to listen to me speak about myself, but I graduated in 2007. I did my MCLIN-Dent and completed my MCLIN-Dent and specialist training in 2013. I then did a diploma in implant dentistry from the University of Central Lancashire, which I completed in 2015, and I've been working as a specialist ever since. Without further ado, I'm going to crack on with the presentation now. The title is obviously Perio Prevention is Better Than Court. A little bit about aims and objectives, because we have to do that as part of it being a CPD course. The key thing is to understand, the aims is to understand the common pitfalls facing periodontal legal claims. It's extremely important to understand the importance of screening and identifying periodontal disease, but also understanding the management of periodontal disease and the tips, and the key factor is the tips to limit the exposure to medical legal claims. Okay. Hopefully by the end of the lecture, you'll be able to ensure that the information that you record in your notes can help you against claims as well. It will allow you to screen for periodontal disease accurately, but also be confident in identifying disease to minimize your exposure when it comes to medical legal claims. Again, this is a little bit about my personal profile. I'm not going to talk too much about it, but the key things I want to try and highlight is, yes, I've been a specialist for probably the last 8-9 years. However, I've worked in general practice. I've worked as an NHS practitioner. I've worked as a private practitioner. So I'm going to try not to sit in an ivory tower and discuss with you all about this is how it should be done and this is what I do, because the reality is it's not what we see out there. So my aim is to tell you, look, I have been a general restorative dentist. I've had a lot of experience in hospitals as a clinical teacher. I've done lots of different things, but I hope from today, and I hope that I'm not classed as someone who sits in an ivory tower looking down at the mere mortals, which is not the way I hope to be. I have to do some initial definitions, but the definition I'm going to use, I'm going to highlight the things that I think are important when it comes to periodontal disease and ensuring that your notes reflect that. So we know periodontal diseases are a chronic multifactorial inflammatory disease, which affects the supporting structures of the teeth. So we're talking about the gingival tissue, the alveolar bone, the cementum, and the periodontal ligament, okay? But one of the key factors that I want to talk about is it's multifactorial. There are many factors that make up the progression of periodontal disease. And that's something that I want to elaborate on throughout my talk, and I'm going to elaborate on my talk, which I think is important to document and notify. Obviously, the characteristics of periodontal disease is attachment loss, okay? So that involves the tissue destruction of the tissues that I mentioned, and the apical migration of the junctional epithelium down, as you can see on the image above, okay? What do we need for a periodontal party? Two things that we need, okay? We need bacteria, and we also need a host response. And I think this is the key thing when it comes to periodontal diseases. It's not as simple as saying it's just the bacteria that cause the disease. We've all seen patients that brush only at Christmas. They come in with plaque levels through the roof, but when you look at their bone levels, they've got very, very minimal bone levels. Then we'll have a lovely patient that we see regularly, cleans meticulously, sees the hygienist every 3 months, absolutely spot on, yet she still has, or he or she still has, progressive periodontal disease. So there are other factors that we need to be aware of, which is important for you to reflect in your notes. And I think that's one of the key factors of this presentation going forward. Talk a little bit about pathogenesis, so what causes the disease to develop. In the past, we've gone through blaming specific bacteria. It's this bacteria, or it's that bacteria, or it's another bacteria. What we now understand is it's more about the fact that there is an interaction between us and our bacteria. We need them. It's called our microbiome. We survive with them, they survive with us. It's a mutually beneficial, and we work in a homeostatic type environment. But what happens is something changes that homeostatic environment. It becomes what we call a dysbiosis. Something changes over that environment. And those factors can be anything from genetics through to environment, through to other factors that are partly that we are responsible for, but some of them that we are not responsible for. Okay. And I think this is again why I'm suggesting that when it comes to litigation or when you're writing your notes, it's important that everything is documented. Okay. Anyway, so periodontology, it's something I enjoy, and I'm sure many of you, some of you do enjoy it as well. But the problem is it's a prerequisite for any type of care that we do, whether it's basic care or advanced care. And it's a prerequisite for all of our patients. Doesn't matter what stage they're at, okay? Whether they need simple fillings, whether they need complex rehabilitation, you need to ensure that the periodontium is healthy and able to sustain whatever you provide. And I think that's the key change that's going on now. For example, implants. In particular, with implants, we find that patients who have a history of periodontitis, not just existing periodontitis, but a history of periodontitis, that's a risk factor for possible implant failure. And we need to discuss this with our patients. Patients with a history of periodontitis, it needs to influence the design of our work in what we provide, whether it's indirect, direct restorations. We need to ensure that the restorative work that we provide is maintainable, easily maintainable by both the patient, the hygienist, and the whole dental team. And on top of that, we've then got to assess and monitor this. But there is another aspect that's important with periodontology, and that's the medical legal importance. Now, I'm not going to dwell too much on this because Paul is going to cover this in a bit more detail, but medical legal is one of the fastest growing claims in dentistry, okay? It can be, and I'll explain what I mean by can be very difficult to defend. They often have the biggest settlement because it involves multiple teeth, and that's something that concerns both dentists, legal experts, medical legal companies, and all aspects of them. But the key factor for this is in order to be able to be classed as negligent or have a problem, there needs to be a breach of duty, or there needs to be a claim and a proven breach of duty. So there's something that's gone wrong with the care that the dentist has provided, and it's below what's expected by a standard group of dentists. And also the fact whatever has been actually breached has actually caused the disease. So there is a lot of scope there to be able to work with, okay? But we need to ensure that what's written down and what's assessed and monitored and documented supports that, both in its accuracy and the fact that it's there in the first place, okay? So during lockdown, I got a little bit bored, so I decided to do a course. So I did a Bonsol on expert witness course, okay? So I've been working as an expert witness now for, well, since lockdown, so coming up to 2 years now, okay? And as working as an expert witness, it's become clear where the major pitfalls are for GDPs. There is consistency amongst the cases that I get referred as an expert witness, okay? Which clearly, for me, looking at the cases, there is a pattern, okay? There's always a pattern. And the reality is, the worst thing about it is all of this is avoidable. So what I thought I'd do as part of this presentation, because first I wrote a presentation that would be very monotonous, going to go through, but what I did then is I looked at all the cases that I'd done, and I looked at the common factors that I see. And then what I thought is I wrote the key ways that I think the best way for GDPs to prevent medical legal issues. And it came down to 4. There's subgroups within them, but there's 4. It's screening of the disease, which is the basic and the element of periodontal care. Identifying the disease, managing the disease, and referrals. Now, I know most of you are going to say, well, Mo's a specialist, he's touting for referrals or wherever he may be, but the reality is every case that I've been involved with has suggested that a referral should be completed if possible, okay? Because without the referral, there is an issue that the fact that you've been unable to treat the disease, but you haven't looked or offered, and doesn't mean the patient goes for it, but offered the option of a referral going forward. So I'm going to break down each one step by step, okay? So the first thing is screening. So within screening, I've classified 2 areas, okay? First one is risk factors. So the risk factors of the individual patient, and the other one is the BPE. Now, the BPE is going to take up a majority of my talk today, okay? And there's a reason for it, and I'll explain it when we get to that section. But these are the 2 things that you need to discuss. Now, I'm going to talk about risk factors first very briefly. So when it talks to risk factors, for me, it's extremely important. As I go back to the first slide that I discussed with, periodontal disease is a multifactorial disease. So there are other factors that come into play besides just what you do with the patient. And in order to ensure that that is documented clearly, you must document these risk factors going forward. So that involves the patient's lifestyle. Okay, so that involves things like, are they smokers? Okay, do they have a live a highly stressful life? Because these are factors that we can see, and it's growing in the literature as well as being risk factors for aspects of gum disease. Okay, now I appreciate when you first see a patient, you know, when you're trying to build a rapport, you've got 10 minutes and it's quite difficult, but these things can be discussed very, very quickly. Okay, because these are factors that tend to have an effect going forward. Okay, and I think they can also be contributory factors. So as an expert witness, I look at these factors and say, well, these could have been contributory factors to periodontal disease, which is something that's a little bit outside of the dentist's remit. Okay, you can't deal with a patient's stress, even though we try to. But you know, we offer smoking cessation advice, but some patients continue smoking. There's environmental risks, so looking at, you know, restorations, the patient's hygiene, massively important. How well are they with their cleaning? Look at the patient's occlusion. Is occlusion having a factor with these periodontal conditions? Obviously, look at the systemic health of the patients, which is in the medical history, but re-refer to it in the notes. Okay, so at least then it's been a clear identification between the systemic condition and the link that you have with periodontal disease. And also genetics. Genetics is a huge risk factor. We see it all the time with our patients, but often it's not documented in the notes. And sometimes if you take a quick family history, anybody in your family suffered from periodontal disease, anybody lost their teeth when they were very, very young, little sentence like that, jot that down, refer to that, explain to the patient that that means you may be a high-risk individual. Okay, that will then allow the patient to understand where they're at going forward. Okay, in terms of where their risk profile is and how high risk they may be. The other thing the main thing I want to talk about is BPE. Okay, now one thing I must say with BPE is the accuracy in BPE sometimes is very, very, very difficult to justify. If you've got x-rays that show exponential bone loss, you've recorded that there's bleeding, there's inflammation, you've got BPE at the standard 000 or 010, 222 or 121 on the lower. It's like a standard thing that you tend to see. There's a mismatch between the two. In some cases, there's no BPE. Now, in those two circumstances, that is very, very, very difficult to not defend as such, but to be able to look at that and say there's anything but a breach of duty there. Okay, the reality is the BPE is a simple and rapid screening tool. It doesn't take too long. It's not too difficult to do, but it's extremely important that it's done well and done accurately. Okay, and the key thing I'd also recommend, it is the minimum standard of care needed at the initial periodontal assessment. Ideally, there'll be more, and I'll come on to that a bit later on, but it's the minimum standard of the screening tool that we expect. Okay, so the BP has to be there. And all it does is tells you whether further examinations are needed. Okay, it doesn't give you enough information for you to be able to then diagnose or assess or confirm otherwise. All it's telling you is there is more things that we need to do. Okay, we need to investigate this further, but that at least will identify in the notes that you have picked that up. You've seen it. You've noticed that there is definitely some aspects of periodontal disease going forward, particularly when you match it up with the radiographs that you've taken, be it bite wings or further examinations. But the reality, what it can't do, it can't be used as a diagnostic tool because it doesn't give you enough information. There is not enough information on a BP to be able to diagnose exactly what's happening. How do you record it? Okay, the mouth is effectively divided into sextants. Okay, so we know this. Again, I don't want to sort of teach grandmother to suck eggs in that situation too much, but it's divided into sextants. Okay, for this, each sextant must have a minimum of 2 teeth. If there's a single tooth, you can incorporate it into the adjacent sextant. Okay, all teeth should be included except for the third molars, because I often get asked that question, what about third molars? Unless the first and second molar is missing, then you get a migration of that of the third molar into a site where the tissues are more normal, as opposed to having the pouch that we see around the retromolar area. Then I would exclude third molars. Okay, but otherwise, if you've lost a first molar or a premolar and there's a migration measly, then I would include the third molars in that. A WHO probe is used. Okay, 0.5 millimeters at the end. The first band is up to 3.5, which is the first black band. Then there's the black band of it, which is from 3.5 to 5.5. Some of them have from 5.5 to 8.5 and 8.5 to 11.5. But majority of what we use is around the first band and the first black band. Okay, and how we do it, we walk the probe around the gum margin. Okay, with a very light force, and we examine all the teeth. Okay, regardless of whether we detect a 4 earlier, we should examine all the teeth because it gives you an idea as to what's going on. Okay, yes, the code 4 would then indicate you need to do a full examination and of the full mouth, but it's important that you do a full BP. So all sextants should have a score. Okay. Who should have the BP? How do we use it? Every patient should have a BP, and it should be repeated at every routine examination, even if it's 0, 1, and 2, but even more so if it's 0, 1, and 2. Okay. If you have a code 3 and a 4, then ideally we need to do a more detailed examination. Now, this is another thing that's constantly missing throughout the notes as well. I'll come to that later on, but that's extremely, extremely important. Again, as I said before, the BP, you can't use that to monitor disease. It doesn't tell you enough as to whether there is disease or not. Okay, and that's something that's whether there's enough disease to manage treatment, or whether you just need to do further examination. All it does, it tells you that there's a problem that needs more detailed intervention. Okay, and if you look at the BP, this is taken from the BSP document. If you've got a 0, effectively you've just got no bleeding. You've got only the tip of the probe is effectively going in there, well below the black band, okay, the first black mark. And then you've got 1, which means there's a little bit of bleeding as you go around. Generally, no tartar, no calculus has been monitored, but there is just a little bit of inflammation. That would give you a BP score of 1, okay? If you've got a BP of 2, then what that would mean is generally still the black band is fully visible when you look in the mouth, okay? But there is aspects of some sort of plaque retentive factors. Now, that could be anything from an overhang, could be through to calculus, could be due to a defective crown margin. Many different things could cause it, but generally that involves a 2. And then you've got BPs of 3. So BP 3 means effectively, as you probe around the gingival tissue, the black band is still visible, but it's partially submerged. Okay, so you've got your tissues largely lie within that second black band, and that's between 3.5 and 5.5 millimeters. Okay, and I'm going to show you a BP a bit later on. A BP of 4 means when you probe through, the black band completely disappears. Okay, therefore there is further management needed. For 3 and 4, further treatment and management and assessment is needed. The other thing to include, which is also extremely important, is any aspects of furcation. Okay, so furcation involves using a horizontal aspect to the probe, which you can see in the image on the top right, and that generally would mean that there is a furcation involvement. Now, the asterisks can be attributed to 0, 1, 2, 3, or 4. Okay, it doesn't have to be only on a BP of 4, because you can have a patient that I've treated, I've stabilized for the patient, but there is furcation involvement, but the tissues have still scored a 1, say, for example. So the black band is fully visible. Okay. In those situations, it's important to document the asterisks, because the furcation is something that explains the severity of the disease that we see as we go forward. Okay. And once we've done the BP and we stabilized it in the maintenance phase, ideally, okay, you still do a BP every time you see the patient, but I personally would recommend a full chart is completed, so a full detailed pocket chart is completed annually. A couple of additional BP points, which I think sometimes gets missed. We don't use BP around implants, okay? The BP would create, due to the soft tissue attachment around implants, it would give huge errors. So I generally recommend, okay, that for implant treatments, every implant that I place or patients that I treat with, ideally a 6-point or a 4-point pocket chart should be completed for every implant when you see them, okay? I think this is quite important to be able to monitor the progression of implants or any implant disease. Not quite sure there's a full remit to discuss that today, but generally I wouldn't include my implants in my BP assessments. Okay. The other thing that's extremely important is that radiographs are mandatory for any code 3 or 4s. Okay, and the main reason for that is it's needed for, well, now with the new classification, it's needed for a diagnosis. Okay, now BP 3 and 4 generally need to have radiographs. That doesn't mean you standardize it by saying, I've got bite-wing radiographs. It's important that the radiographs represent the severity of the disease that we see. And I'm going to come on to that a bit later on. Now, I've got a little video here just showing you how I take a BP. This is one of my nurses who doesn't suffer from periodontal diseases. It saved me having to gain consent for today. But this is me showing how to do a BP on both the buccal surfaces, the lingual surfaces, the labial surfaces, of the palatal surfaces. So it gives you a bit of an idea. Apologies if the video is not so clear. It's clear in my view. If it isn't, please leave a message in the group and I can always replace it or repeat it going forward. Okay. So it's me walking around the probe. So we're doing the lower right side. Okay. Just walking it gently, keeping the angulation of the probe to the long axis of the tooth, gently walking it around the gingival margin. You can see pristine gingival health with my nurse. This is now the lingual of the lower right side. Again, you can see retraction of the tongue there, working it through, keeping the long axis of the tooth all the way around the gingival tissues, walking through. This is now the maxillary incisors, so the anterior sextant, walking it around the gingival margin. Okay, generally walking it through the gingival margin. Light touch, light pressure. I'm going slightly slower. It can be a lot quicker than this, okay, but I've generally did it slowly just to be able to see both the angulation of which you probe and the importance of ensuring that you visit all areas of the gingival tissues, okay? And you'll see the same thing now with a mirror into the palatal surfaces. Hopefully you can see that reasonably well. So starting on the distal and the canine on the left, walking it round, ensuring, and this score obviously as you'd expect it to be with my nurse who works for me for my periodontal patients, it's a 0. No aspects of bleeding. The band is fully visible at all times and generally quite healthy, okay? Now that completes the BPE aspect of the discussion. Now the BPEs are often missing. I think, like I said previously, and I'm going to say it again without any apologies, it's extremely important that the BP is done both accurately and also done thoroughly, okay? But also at least as a minimum done, because there is nothing we can do when there is no BPE, when there is no screening of the disease whatsoever. And if there's no screening, it then follows on that there's no identification, there is then no management, there is then no referral. So all of that afterwards generally leaves you very, 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 very exposed. And I cannot expand on that anymore. And I'm sure Paul will expand on that a bit later on, okay? Because the BP is the foundation of the rest of the case, okay? Without that, everything else falls on its shoulder. And the only thing you can do is unfortunately agree with every allegation that then comes after that, okay? And this is direct experience. I'm telling you, this happens in numerous cases that I've had over the last 2 years. Next thing I want to talk about is the identification of disease. So we've screened it. We've found that there is the possibility there is periodontal disease in this patient. So now we need to identify it. Radiographic examination, a detailed periodontal assessment, and a diagnosis. These 3 things every single case, okay? Failure to take radiographs, and not just take them, but the appropriate radiographs, and I'll explain what I mean by that. Fail to fully do a full periodontal assessment, okay? And also a fail to complete a diagnosis, okay? To formally tell the patient or write in the notes, this is the diagnosis of that patient, okay? So I'm going to work on that now. So radiographic examination, as I said, an accurate radiographic examination. You cannot identify and diagnose periodontal disease without radiographs. Previous diagnosis, previous classifications have not really helped with that. The new classification is solely reliant on radiographs. Most of what we do is based on what we see on the radiographs. Now, I'm sure some of you are sitting there thinking, can't stand the new classification. And I promise you, when it was released at Perio in Amsterdam, we all felt exactly the same, okay? However, I think the BSP have simplified this document massively, okay? And I think the more we use it, well, first of all, we haven't got a choice because it's here, but we have to get used to using it. Now, it's not within the remit of this presentation for me to discuss how I use the new classification. I've done plenty of talks regionally for that. Happy to have that as a separate topic should you wish to discuss that. But it's important that we do use the radiographs because they are needed for the classification. You cannot have one without the other. And why is that? Because you need to see the crestal bone levels wherever they may be. In order to do that, you need to be able to see the radiographs. You'll be able to see, on the radiographs, the bone levels. Okay, if you can't see those bone levels, then there is no way for you to be able to diagnose, monitor, assess, and see the severity of the disease. Okay, so the appropriate radiographs can be bite wings if the bone is visible on the screen of the bite wings. But again, bite wings largely up on the posterior teeth. If you've got anterior teeth that then have bone loss, then it's extremely important that you have the appropriate radiographs for those areas. And usually we're talking about periapicals, okay? Ideally, in order to fully assess the length of the root, in order to assess how severe the disease is, if you can see the full length and shape of the roots, that will allow you to monitor disease better. Because if you just find that you've just got the crestal bones in that screen, you don't really know how long the roots are. A typical example will be if you've got a 6mm root and you have 3mm of bone loss, that's 50%. You have a 12mm root, it's a lot less. Okay, you're looking at saying it's more 25%, but you wouldn't know that unless you've got the full length of the root. So radiographs is something that the new classification kind of pushes us to make sure that we take it. So in my eyes, it works really, really well with that scenario. Okay. If you can see the full length of the root, you can then comment on the percentage of bone loss. So how much bone has been lost? And that gives you an idea to be able to monitor the progression of the disease. Another clear issue amongst the clinical notes or the clinical negligence claims that I see, okay? A lack of monitoring of the disease going forward. Now, if you've got the appropriate radiographs, you can monitor this. If you've got the pattern of bone loss, so if you've got vertical bone loss, intrabony or furcation lesions, these are extremely important. Why? Because they don't respond to non-surgical therapy in most cases. So therefore, you've done as much as you can, referrals indicated, patient declines, you've done everything you need to do, okay? Because those more complicated bony anatomies, furcations, intrabony defects, they actually require referral. It's not within the remit of a general dental practitioner to be able to deal with those situations. Okay, the same way you won't deal with more complex endoanatomy, okay, or a significant tooth wear case that is outside of your remit. So you refer, patient declines, accepts, you've got it in the notes. Okay, so these things are extremely important when you're recording your radiograph examination and also reporting on the x-rays. Extremely important. You've got to make sure you write down all aspects. Yes, the grade and everything is important, but the actual report is hugely important. Okay, in terms of allowing an expert witness to look at this and say, look, clearly the disease has been identified. It's been discussed with the patient. They've noticed that there is bone loss, there's furcation involvement, there's an intrabony defect. These things have noticed that this disease actually was fairly progressed when the patient attended in the first place. Okay, or they've noticed and identified that in 2007 it was like this, and 2009 there's this progression, or it had remained stable. So how much of that time is reliant on you as the dentist? Very minimal, because during that time period, everything was relatively stable. Okay, so I hope that kind of makes sense. This is a typical example. Okay, so I've got an OPG of a patient that I use, and I've got consent for using. But you can see around the posterior molars, you've got intrabony defects, you've got furcation involvement. But if we were to take bite wings of, I hope you can see my cursor just on the posterior area here. Okay, you won't be able to differentiate between bone loss in this area to bone loss on this tooth. Now you can see they're both at very, very different stages of the disease. Okay, one is effectively hopeless and needs extraction. Others probably need some treatment to be able to prolong the life of the teeth. Okay, so this gives you a bit of an idea as to what's happening. And I use DPT or OPGs all the time. Okay, so I do use them as well as that, particularly when I'm dealing with wisdom teeth, possible extraction of wisdom teeth, location of the ID canal, little things like that. So as long as you've got an appropriate radiograph for that patient to be able to see the full length of the teeth, then that's beneficial. Okay, so usually my initial assessments, I do a fair few OPGs. I do periapicals as well. Mostly when I'm doing surgery, I tend to focus predominantly on periapicals and more detailed radiographs going forward. Okay, don't get me wrong, if the bite wings tend to show bone levels comfortably, you're okay to assess and say that's fine. You don't need to start delving into PAs and all the rest of it, because then we're not working within our remit, if you like. Okay, so hope that explains things a little bit more. Detailed periodontal examination, again, I know it's frustrating, I know it's time consuming, I know remuneration issues can be a problem, but unfortunately they are raised by solicitors when it comes to deficiencies in a patient's care. All right, anything that's got a code 3 or a 4 will require a detailed pocket chart. The new PSP guidelines, which are all available, and I can get them to you. You can contact me or contact Paul or Emma or whoever's on the line to be able to for me to send you them or links to them. But the reality is, if you've got a code 3 or a 4, you need a detailed pocket chart, because the BP doesn't tell you enough information. A code 3 can be relatively treated slightly differently. With a code 3, you can start with professional mechanical plaque removal, also known as a scale and polish, and super and subgingival cleaning, just to tidy up, improve oral hygiene, review at 3 months, and then decide then whether you need to do further further detailed pocket charts. A BP of 4 in any area generally would require a full mouth assessment. But don't forget, code 3 and 4 already require radiographs. So that's already been taken. So you're able to see the extent of the disease before then. Another thing that's extremely important, and it comes up in the case as well, is a lack of gingival inflammation, or the lack of recording of gingival inflammation, also known as bleeding on probing, because this is also extremely important when you are assessing the stability of a site. Okay. Now, I don't think there's any cases that I've come across that will argue between a 4mm pocket without bleeding being stable and a 4mm with bleeding being unstable. But usually in cases where there's usually never a detailed pocket chart, if I'm honest. Okay, there's no detailed periodontal examination, but bleeding on probing is important to be done alongside a detailed periodontal examination. BP guidelines suggest, I tend not to do this, I tend to record everything, but the BSP guidelines do state that it's only necessary to record 4mm pockets and above. So you could just only record the sites that are 4mm, and the rest of your chart could remain empty. Okay, those that are 3mm or less. But bleeding is extremely important to record as well. Other things that you record, which is optional, I think it does help with regards to the prognosis and the stability of the mouth that we're dealing with, is things like mobility. Okay, recession, furcation involvement. These all affect the prognostic factors that we discuss when it comes to the likelihood of the patient losing the teeth, irrespective of what's happened. Okay, and what it allows you to do is to look at, it's like a mouth map. It allows you to look at the extent and severity from the soft tissue, as in the pocket, and alongside the radiographs, and it gives you the detail that you require. And this is the reason why every single case that I've dealt with has suggested that they're in breach of duty due to a lack of detailed periodontal examination. And the guidelines that they tend to use are the BSP guidelines. Okay, and they are guidelines, I believe that, but they do believe that they are a body of which talk to all aspects of periodontal care of patients. Okay, so the BSP guidelines will be the guidelines that will be repeated to me, and I use as a guideline to, as part of my cases, to either to try and defend or to try and assess what's happening in that patient case that I'm dealing with at that moment. Okay. Diagnosis, I'm not going to dwell too much on this. Okay, there's more on here I could talk about, but my time is limited. But I've said before, diagnosis is an important part of classification. Okay, the BSP have made it very simple, and I've actually, in my talk that I give, I try and make it even more simple with just 4 questions that most patients tend to ask themselves. But again, that's not within the remit of today, really. But when we're looking at the stage and grade, we're looking at stages of severity. So how severe is the disease? 1, 2, 3, or 4. Grade, looking at the patient, looking how old they are, what is the risk of the disease progressing at a higher rate? And that's where we look at saying it's A, B, or C. Okay. A diagnosis now, the way they've structured it, can tell you a lot just by telling you what stage and what grade it is. Okay, it can tell you already within that the severity and the identification of the disease, as long as you've got your radiographs, because without your radiographs you can't stage or grade anyway. Okay, the other thing that the new classification does, it incorporates your risk factors. So these are the risk factors that it's important to identify that has contributed to the disease, as well as whatever the patient may claim has been done by the dentist. Okay, so this is why I think it's extremely important that these things are documented. I know you can hear a pattern of me repeating myself, but I don't think I can emphasize that enough. Management, okay, looking at how we manage disease, these things are extremely important. Again, common questions that come up in all cases: is appropriate oral hygiene advice given? Is the appropriate treatment done? And I've put in brackets there, not scale and polish, because that's what I see significantly in the notes. Okay, scale and polish completed. That's not a treatment indication for periodontal diseases. Appropriate referral if there's no improvement or if there's been a difficulty in stabilizing the disease. Appropriate maintenance. Okay, so has the patient been given appropriate recalls? Have they been seen more regularly? Have they identified the fact that they need to be seen more regularly? And are the dental records sufficient enough for it to be able to be up to scratch, if you like? Okay. Appropriate oral hygiene advice: home care, home care, home care. Cannot elaborate that enough. Okay, because periodontal disease, no matter how great you are, how much training you have, doesn't survive unless you've got the patient there with you at home doing what they need to do. Okay, if a patient lacks motivation, or there are factors that affect their cooperation, be that personal, be that physical, it's important, we have shown to show the patient how they need to clean, okay, difficulties they may have, show them how they need to improve, okay, or ways to try and help them, because that will then come back and say, well, actually, the patient wasn't told what needed to be done, okay, despite there being a clear lack of motivation. So you need to important that you document that. Show the patient, not just discuss with them, show them, okay, show the patient how they need to clean, show them how they need to use incidental brushes, okay? And I think it's key for you to discuss with the patient their personal risk profile and document it, okay? Because you're telling them the reason you have gum disease, yes, one factor is the fact that you're using the wrong end of the toothbrush, but there are other factors that are coming into play, which is making it even harder for you. Now, unfortunately, you have these risk factors, other people don't, but your focus has to be to ensure that you cater for those. You balance those out by making sure your home care is exemplary, not just good. It's got to be superb. Okay, so these are the things that I think are extremely important to document that you've discussed with the patient going forward. Again, I know it's difficult when you've got 10 minutes, okay, and I appreciate that, but these can be done over a period of time. It doesn't have to be, you can spend a lot more time at the beginning with the patient, but it's extremely, extremely important, because these are the questions that they then tend to throw back in when they look at the notes afterwards. As I said, often routine scale and polishes are classed as periodontal treatment. They're not, okay? A 15-minute scale for a patient with stage 4 grade C is not appropriate, okay? There's a huge difference between maintenance and active treatment, okay? Non-surgical therapy is mandatory. It's the initial stages of treatment. Once you've identified and you've discussed that the patient requires management, you need to do your non-surgical therapy. Local anesthetic, if it's required, okay, I don't think it's a prerequisite. Some of them state that it is, it isn't, and I've argued the case accordingly. But non-surgical therapy, it needs to be written down. Okay, it needs to be written down that that's been done and appropriately discussed with the patient. That it's a clear difference between that and a scale and polish. A clear contraindication is a poorly motivated patient. Okay, now again, documenting that is it's not easy enough just to say the patient's poorly motivated. If you can talk about the fact that previously you have discussed this, there's been no changes to the patient. The only time I use plaque scores is when I'm trying to justify the fact that the patient's not doing great. I don't think it's absolutely necessary, but you can definitely put it to the patient and ensure that you've written in the notes that you've given all the information, but the patient has not acted on it. However, I personally feel, and this is my personal feeling, okay, starting with at least one course of one cycle of non-surgical therapy is worthwhile doing. Some people don't start until the patient reaches a certain level. Sometimes motivation can be gained through initial non-surgical therapy. And the fact that you've done it once and you won't repeat it until the patient reaches a certain level sometimes can help, because if they've got significant tartar or tenderness, sometimes it's very difficult for them to be motivated with their home care, okay? This is the BSP UK clinical guidelines. If you haven't got this document, I think it's pretty good. It looks complicated. It looks like there's arrows going every which way, but generally it works quite well. The crux of it, and I'm not going to go over this too much because again, this is the remit of a whole different lecture. But the reality is, step one is what we do at the patient at the initial stages. Okay, this is given all NHS practitioners or private practitioners a clear guide at what needs to be done. Okay, talks about explaining the disease, the risk factors, the oral hygiene, the behavior changes, reducing the risk factors that are present in the mouth, home care, all the rest of it. Okay, talks about professional mechanical cleaning, recall before you've even started. Okay, only then do you move on to stage 2 once the patient has shown all of these factors. Okay, but they still do tailor for some supra and subgingival mechanical plaque removal. Okay, so that's scaling above and below the gingival margin of all the clinical crowns. Okay, if you need this document or would like this document, please contact me. I'm happy to do so, and we can discuss that. If only then, once they get to that stage, do you even start doing subgingival instrumentation. Okay, so this is kind of given everybody a guideline to follow. You can justify your way of treating patients, but the reality is it still involves subgingival instrumentation, risk factor control, and everything that I've mentioned up till now. A couple of things I'd like to draw your attention to. I mean, this is something that you can all read in your own time, and it's like I said, it's not in the remit of today, but look at the top tips. Okay, this is the focus. Patients should be made aware that their self-performed plaque removal is of the largest treatment benefit. Engaging the patient in verbal contract to perform daily plaque control. These are good sentences to use in your notes, and I've got a slide later on to show you that. Again, incidental brushes, simple, that's got to happen, okay? And with the incidental brushes, the big thing is the right size, okay? A red and yellow is not the appropriate size, depending on the size of the patient, spaces in between the teeth. I show my patients, I know it's difficult, but if you can even get your hygienist, or you can get somebody to show the patient, OHI nurse or something like that, just to go over and show the patient, you've done everything you can to cover those areas. But the individual's patient's abilities need to understand their dexterity, their selection of the toothbrushes and incidental brushes as well. Quickly talk about non-surgical therapy. What do we aim to achieve? Clear reduction in pocket depths, bleeding indices, and ideally excellent home care. Okay, that we can recommend as being a good result. However, sometimes after non-surgical therapy, sometimes it's not enough. Usually it's either the patient's fault, it's our fault, so we've not done it right, the patient's not done it right, or not contributed and not done their role. Or the other thing it can be is due to the anatomy. Okay, and that's what I'm talking about when I talk about when is non-surgical therapy not enough. Talking about intrabony defects, furcations, very, very deep pockets won't go, or they can do, but they don't always go from a 9 to a 3 millimeter pocket. Okay, sometimes they need further treatment. That could be a second cycle with yourself, it could be a referral to a specialist, a hospital, and there are different anatomical variations that can also cause issues as well. Okay. Maintenance wise, recall, very, very important. That's another thing that comes up often. You've got to ensure that the patients are seen in an appropriate manner. So it should be ideally, once you're in a stabilization phase, for the first year at least, should be every 3 months. Most of my patients continue on 3 months, but I would start with a 3-month recall. Or if a patient has first been identified as having disease, don't leave it for 6 months. Leave it to a shorter period and make sure they understand why they're being seen shorter and because of their risk profile. Okay. Again, when they do come in for maintenance visits, if they see the hygienist or if they see my hygienist, they get, well, it's now called professional mechanical plaque removal, but they get supra and subgingival cleaning in the areas in particular that you've highlighted as being a problem. So if you've located an anatomical pocket on, or a pocket on a distal of a 7, make sure you write that in the notes, discuss with your hygienist to focus on those particular sites. Okay. And again, throughout, always reinforce the home care and the patient's responsibility, okay? Because that way you've clearly identified that this is the importance of the patient to do what they need to do. Referral, like I said, I know this is going to sound like I'm touting my own horn to get patients to refer, but the reality is every case I've ever dealt with so far has discussed the failure to refer appropriately. We do it for endo, we don't do it for tooth surface loss as much as we should, but reality is if something's not working or not happening, we've got to offer the referral, okay? Especially if there's any non-healing sites or any anatomical variations or something that we just don't know, okay? Intrabony defects, furcations, advanced disease. So we're looking at stage 3 and grade C. So you're looking at saying severe disease, which is progressing at a rapid rate, or very severe disease that's either progressing as you'd expect, but also at a rapid rate. It's worthwhile doing so. Just because you offer it and the patient declines it, document it in the notes, okay? At some point, they'll either agree to it, but at least you know you've offered the patient the option of having to do that going forward, okay? Now, these are some typical examples that I thought I'd show because I've talked very much about clinical notes at the moment, but these are some surgical photos from aspects that I've done. So I've done some non-surgical therapy, and you can see quite clearly we've raised the flap. And if you look at these sites, there is no way on earth, just by doing non-surgical therapy, some of these sites are going to heal, okay? And coincidentally, even after surgery, sometimes they don't heal, but the aim of this is not to allow the tooth to survive forever, it's to prolong the life of the tooth going forward, okay? So these are the types of things that look on the x-ray like there's a slight intrabony defect or a slight wall defect. Now, I spend a lot of time doing non-surgical therapy. I don't mind sharing that this is a patient that I've done non-surgical therapy on, and I've spent a hell of a long time, probably more than all of you would do on a single site, and I've still left calculus below the gingival margin, okay? Very difficult to get to, but these are examples of areas where these are not going to heal just through non-surgical therapy. And this is why no matter what happens, they say referrals should have been offered, because this is outside the remit of what a general dentist would be able to identify or even treat. Some of you can, if you can, brilliant, don't get me wrong, I'm happy for you to do so. But if not, then at least document the referral, whether it be to a hospital or whether it be to a referral specialist in your local area. Again, this is another typical example of a furcation lesion, just to give you an idea of what it looks like when you raise a flap. And when you clean the area, the patient now can clean interproxim between the teeth, and you've stopped the progression of the disease. Okay, so just some little examples as to why referrals can sometimes be beneficial. Coming towards the end now, with regards to appropriate dental records, ensure you record your conversations. Okay, risk factors, extremely important. Okay, home care alterations, massively important. Ensure your BP is accurate. Okay, do it as a bare minimum, but ensure if you do it, it's accurate. And look at your radiographs, look at the x-rays, look at the bite wings that you've taken. If there's bone loss around those areas with inflammation, it's likely your BP that you may have written down as 000 or 121 is incorrect. Okay, so in those situations, make sure that, because if the two don't match, you're starting off, when you're looking at the records as an expert witness, very, very difficult to say anything more than that. Okay, treatment plans, ensure you're right, that it's not just a scale and polish, directions are clear, it's non-surgical therapy, and document that your referrals are being discussed as well. Okay, problem with consequences of neglect, again, I'm going to briefly talk about this because Paul is going to really send the message home, I do feel, is that periodontal neglect often includes multiple teeth. So there's always a multiple. The costs are multiple. Everything tends to end up happening. The other thing with periodontal disease, it involves lifelong maintenance. This is something you're going to need for the patient forever. That's calculated into the costs. Replacements is incorporated into the cost. And they want the solution that's closest to your natural teeth, which unfortunately, rightly or wrongly, is an implant. Okay. And then they also talk about the replacements of the replacements. So that's the figures that they talk about with the longevity of an implant, a crown, or a bridge, or whatever it may be. And the other thing they tend to claim for is the mental health strain that the patient has gone through, okay, which they add to as well. So these things are really important, and this is why the numbers tend to go crazy. But again, I'll let Paul expand on that a little bit more. There's a document by Shazad Salim, which I think is a very good document. And I've credited him for this, but these are helpful phrases that are often used in the notes for patients. Okay, and it's in his document called Healthy Gums Do Matter. It's a Northwest project, I believe. Okay, and it's available, I think, on if you type into Google. And these are the sorts of phrases that he has written down as good things to discuss in the notes. I'll just go through each one very quickly. So the main thing would be patients advised of mild, moderate periodontal disease. The patients warned of tooth mobility and tooth loss related to their gum disease, not just talking about mobility and tooth loss. Advised smoking related to gum disease, the risk factors and the condition and the poor response to therapy. Advised the oral hygiene is not adequate to support formal periodontal therapy. Advised the patient needs to improve plaque levels to support periodontal therapy. And patients shown how to use the ID brushes and the sizes. Again, what I've already discussed, and then discuss referral to a specialist. Now, this is part of the NHS document that Shazad Salim has written. It's supported by the BSP. This is where your strength lies. Okay, you've got everybody supporting you going forward. Okay, now that comes to the end of my talk. I apologize if I have talked quite quickly. I was very concerned that I would go over the time that I had attributed to me, but that's me coming towards the end of my presentation. I'm going to pass you now over back to Paul. And obviously, if we have time at the end, if we do get to do questions, brilliant. But now over to you, Paul.
Thank you very much indeed. All right, some of you may know me. I work for Colosseum, and I've also been a dental legal advisor for 25 years. Mo has just done a brilliant discussion about the diagnosis and management of periodontal disease. He has done it in great detail. I just want to say a few words about the dental legal challenges associated with missing or failing to record periodontal disease effectively. Over recent years, we've seen a steady increase in the number of cases where claims have been lodged for periodontal neglect. Typically, the patient will have been seen regularly over a period of years, having routine examinations, regular bite wing x-rays. There will be evidence of periodontal inflammation, deposits of plaque and calculus, and successive bite wings will show a steady loss of bone height, which goes unnoticed. In cases where there is periodontal disease, there is no reference to a detailed periodontal assessment to the identification of the changes of periodontal disease, to an intensive oral hygiene regime, to intensive scaling and polishing, and to referral to a specialist as required. Dentists may not take the necessary action to intervene to halt and document the deterioration of the periodontium by the necessary investigation, advice, and management. Such failure will be viewed as negligent and cannot be regarded in any other way. A recurring element in such cases, as Mo has so thoroughly explained, is the basic periodontal examination. It must be accurate. It is essential that you know how to do it. If it is wrong, or if it does not accord with other findings, it will catch you out. Please ensure you understand what Mo has clearly explained and demonstrated. Periodontal disease may not come to light until a patient starts to develop loosening of teeth. He or she will see the dentist and be told that there is long-standing periodontal disease. At this point, the patient is usually referred to a specialist who will explain that it has been slowly progressive over many years. The patient will be told that the disease can be largely halted but not reversed, and probably that a number of teeth will be lost. Many patients will realize that for this to have happened, negligence must have been involved, and their next stop will be to one of the dental negligence solicitors, who will delight in lodging a claim. To do so will be so easy. The notes will not show effective diagnosis of the disease with a comprehensive examination, an accurate BPE, and if appropriate, further detailed charting. The treatment plan will not recognize the poor state and detail the treatment necessary to achieve arrest of the disease or referral if appropriate. The X-rays will show the bony deterioration apparently not recorded by the dentist. Finally, the mouth itself will show the poor periodontal health, possibly plaque and calculus, loosened teeth, and general deterioration. For the dentist who has not recognized advancing periodontal disease, there is frankly likely to be no defense, because the examination, notes, and treatment plans do not provide an indication of the seriousness of the problem and the effects to manage it. If the dentist does recognize the true periodontal state, but cannot engage the patient, the notes must clearly show what has been explained, what measures have been proposed, and clear documentation of the patient's failure to cooperate. For the dentist, the receipt of a claim is very unpleasant. Claimant solicitors will try to squeeze every last element of criticism into the claim. They will list every affected tooth, the extent of the bone loss for each tooth over the period of neglect, the teeth which will prematurely be lost, and the need for replacement. The claim will be for referral to specialists and treatment to arrest the disease and try to prevent the loss of as many teeth as possible. The claim will include the cost of extractions and implants for each lost tooth, which might require pre-placement of bone grafting. Not for such patients will be a denture. Each implant and crown will be priced at between probably £2,500 and £3,500. And if the patient is likely to lose, say, 10 teeth, then that cost will initially be £25,000 to £30,000. Furthermore, they will claim an implant replacement every 15 to 20 years. If the patient is young, this may then be 2 or 3 replacements. The bill therefore rises markedly. In addition, there will be pain and suffering, the mental trauma to which Mo referred, the loss of amenity, cosmetic problems, difficulty eating, and so on. apart from the emotional trauma, which apparently inevitably follows loosening of the teeth. So what might the value of periodontal neglect be in, say, a 35-year-old with a couple of loose teeth, where the periodontal disease has been neglected for some years? Perhaps it will result in a damages claim of £15,000 to £25,000, and if that claim is settled, claimant and defence legal fees may add another £30,000 or more to the bill. So the indemnifier may be faced for this one case of periodontal neglect, resulting in the loss of, let's say, 2 teeth, with total costs of at least £50,000. Imagine the costs if there was widespread prolonged neglect with loss of many teeth. We are seeing total claims in excess of £100,000. And as I said at the outset, such claims are rising because they are so easy for the claimant's solicitors. For the dentist, it might not even end there. An angry patient may easily complain to the GDC or to the NHS or both, and those organisations would be likely to follow up such complaints. For the dentist, it could be months or years of anxiety and concern, demands for reports and explanations for the neglect, reviews of other patient records, attendance at hearings, and even conditions on registration. So that's the black cloud, but dentists can avoid this problem entirely. Mo has very carefully detailed what's required of patients with soft tissue disease, and indeed what should be carried out on all patients who receive an examination. There should be a detailed inspection of the soft tissues as well as the hard tissues. If there is any evidence of periodontal disease at all, it must be recorded and the necessary BPE charting done accurately. Bite wings and periapicals taken of areas where bone loss is worst must record the degree of bone loss. This needs clear explanation of the disease, its progress, its consequences, and the actions necessary. Details must be recorded. I accept that it will take a little time, but it cannot be neglected. Sooner or later, any dentist failing to identify disease will pay dearly with a claim or possible referral to a regulator. The note should be comprehensive, but I would counsel you to try to avoid criticising the dentist or dentists providing previous care. You will have no idea when that patient was seen by them, whether they attended regularly or erratically, whether they ignored all advice given, and whether they failed to seek specialist opinions that were advised. But it is essential that the patient is not left in any doubt whatsoever about the current disease state. So periodontal disease and neglect is becoming increasingly important as a source of complaint and claim. In general, it is negligent not to identify and manage it appropriately. Soft tissue examination must be thorough, the BPE meticulous. Radiographs should be appropriate and must include reporting bone loss. Management should be clear, emphasizing oral hygiene, providing intensive treatment, and making sure that there is appropriate referral or follow-up. If there is any doubt in your skills any doubt about your skills in identifying periodontal disease, please do further periodontal study and ensure you can do a BPE accurately. Believe me, periodontology is becoming more important. It is distressing when it is missed and when it leads to a complaint or a claim. And it is only the merry band of dental negligence lawyers who rejoice in the misery that they can inflict upon you. I'm sorry if that has sounded a bit negative and gloomy, but I'm afraid it is becoming an increasing problem. And I must ask you all to make sure that the periodontal status is adequately described with every patient that you see. Thank you very much indeed. I don't know how much time we've got for questions, if any. We've just about reached our hour.
There are some questions here, Paul. I mean, obviously,
can we take just one or two, as we've overrun a bit?
Yeah, there's not that many. There's only a few, but I'm happy for people who obviously are happy to, if there's no question, that's fine. But I can quickly answer these if we're okay for time.
Okay, go on, let's have them.
There was a question: when can we refer to the NHS periodontist? They asked for perio charts on PDF and compare in special formats. We had difficulty doing this at the clinic, and if they smoke, can we still refer? If I'm honest with you, when it comes to this scenario, it's each individual hospital has their own guidelines. They will have, and it depends on their remit. I can't really get involved too much with that. Sheffield has a different one. Leicester has a different one. They have different criteria based on their own funding requirements. So if I'm honest with you, I can't really answer that too much, but I do know any private specialist will accept any of those. Okay. How often should you repeat the radiographs? It's based on the risk assessment of the patient. Okay. If you see progressive bone loss measurements change, otherwise I'd look at saying I'd take my measurements every year and radiographs as appropriate, like we do with caries. If someone's showing inflammation, slight increase in the BPE from a 1 to a 2, you may say, has there been any changes? Has anything happened? If you've done a detailed pocket chart annually and there's a change, take an X-ray. I don't think there's a fixed number that you should generally consider saying I've got to take X-rays all the time. There's one that says, are we starting AR19? I'm not sure what that means, so forgive me about that. In the BPE, are the interproximal areas not measured while walking the probe? They absolutely are, but you've got to make sure your probe is vertical. The minute you angulate your probe, suddenly you're going into a black band because of the angulation not being correct, which is what I was trying to show in that video, but obviously not very well. But yes, the interproximal is part of your walking the probe from mesial to distal. So that should be absolutely recorded going forward. Another question now, if a patient needs surgical treatment but refuses a referral, should you continue to treat them non-surgically as best you can, explaining the limitations of treatment, or just document that they have refused a referral? I think once you've done your initial stability and you feel that the remaining sites are due to anatomy or whatever it may be, then I would suggest that you go into a maintenance regime where you ask the hygienist or whoever's dealing with the maintenance, could be another dentist or yourself, just generally debride those areas just to slow the progression down, reinforcing the fact that really what this needs is specialist intervention. Okay, I wouldn't necessarily mean you still do non-surgical therapy every single time. I think supragingival and subgingival plaque removal is good to do on a regular basis for those non-responsive sites that they've declined treatment for. But when you do your annual measurements, you might find that actually there's a need for further debridement, and you may then decide to do that. But I wouldn't do non-surgical therapy every single 3 months because there is some removal of the root surface going forward. So that should answer that question, I hope. Another one says, is there any way of getting the screen slides? I think we're recording, so unless you don't like the sound of my voice or the look of my face, you can always just watch the presentation again should you require. But if you need the slides, if you speak to the organizations, I'm more than happy to get them over to Emma or Paul. That's everything. I hope I've answered that. Paul, that's the end of those questions, if that's all right with you.
Thank you very much indeed. Well, I hope that this has been helpful and useful. We are really grateful to Densura for allowing us to put this on. As it says on the notice on the screen, you may well meet Emma and Ewan, who are two of the team from Densura who will be visiting practices. Thank you for watching. Thank you for listening. You know where the slides are. We shall be pleased if you would like to have a copy. Thank you and good night. Thank you.